מאוד נגולי להציג את המרצה שלנו היום, פרופסור איתן בלומנטל, מנהל מחלקת עיניים של בית חולים רמב"ם מזה כשנה וחצי. פרופסור בלומנטל התמחה בניתוחי גלאוקומה וקטרקט, ובתחום המחקרי הוא עוסק בטכנולוגיות אבחנתיות וניתוחיות, בהדמיה של עצב הראייה והרשתית בגלאוקומה ובאבחון מוקדם של מחלה זו. פרופסור בלומנטל החל את דרכו המקצועית בבית הספר לרפואה של האוניברסיטה העברית, והתמחה במחלקת עיניים של בית חולים הדסה בירושלים. משם המשיך להשתלמות על בתחום הגלאוקומה, אותה ביצע באוניברסיטת קליפורניה בסן דייגו, בהנחייתו של אחד המומחים המובילים בעולם בתחום זה, פרופסור רוברט ויינרב. בתקופה זאת השתלם בכירורגיה של גלאוקומה וקטרקט והתמקד במחקר אודות הקשר בין הפונקציה, התפקוד הראייתי, לבין הסטרוקטורה, הנזק ההיסטולוגי בגלאוקומה. לאחר חזרתו ארצה ניהל את שירות הגלאוקומה בהדסה במשך כתריסר שנים, וכיום, כמו שאמרתי, הוא מנהל את מחלקת העיניים של רמב"ם. פרופסור איתן בלומנטל פרסם מעל 100 פרסומים מדעיים בעיתונות הבינלאומית, והוא חבר באדיטוריאל בורד של העיתון המוביל בתחום, Journal of Glaucoma. הוא פיתח מוצרים טכנולוגיים המשמשים מנתחי גלאוקומה ברחבי העולם, ומשמש כיועץ לחברות טכנולוגיות העוסקות באבחון, הדמיה וכירורגיה של מחלות עיניים. היום פרופסור בלומנטל ידבר על קטרקט וגלאוקומיה, ולפני שאני קורא לו שני דברים: אחד, נא לכבות את הפלאפונים, ושניים, ההרצאה תהיה באנגלית מכיוון שאנחנו מסריטים אותה לצרכי בית החולים וזה עובד טוב. אז פרופסור איתן בלומנטל, בבקשה.
תודה על ההקדמה. As you've said, I'll switch to English, and I need to see the slides as well. It's okay with you? Okay. Today I'm going to talk about glaucoma, ophthalmology, and a little bit beyond that. And I hope to make this talk interesting for you. Medicine and research is all about curiosity. And even though medicine is a very strong and powerful pillar, each and every one of us would like to contribute at least something small, and hopefully that something will stand the test of time. This slide used to be called conflict of interests. Today we prefer to call it industry affiliations. And if you look closely at the photo, help me out. Which of the two is the clinician scientist and which is the company? Let's start by entering the fascinating world of microsurgery. It's not the kind of world you're familiar with. If you err by a centimeter, you're no longer in the eye, you're in the nose. If you err by 1 millimeter, you destroy the eye. If you can be accurate to 100 microns, you should probably seek a profession elsewhere. And if you can be accurate to 25 microns, it's a great start, and please continue practicing. And just a reminder, a red blood cell, which we'll meet a little later in the talk, is only 7 microns in diameter. This is a cluster of surgeries that shows the various disciplines in ophthalmology. Just sit back, listen carefully to the words. Oh.
If you had one shot, one opportunity, seize everything you ever wanted, one moment, did you capture it? Just let
Suture lysis is a technique where we open sutures that are buried under the conjunctiva within the tissue after glaucoma surgery. And as you can see in the arrow on the top left, you can see a suture broken. That little gap in the suture missing is a laser shot. And in this way we can interfere or interact with things we've done during surgery later on without actually going back to the operating room. And this is a suture lysis lens that I developed, and it's now a commercial product that assists in doing that specific procedure I showed you. And there's always something unique when you try to break the envelope. And in this case, the unique aspect on the right insert, you can see that little bump in the center of the lens. And that really what gives it the extra edge. And if you look at this photo published from the Archives of Ophthalmology, they've compared what was until then existing as far as visualizing sutures in the tissue. And in a relatively difficult case, they showed that on the left, you can barely notice the suture and it's not amenable to laser surgery. And on the right, you have a good enough view to actually break the suture. I want to talk a little about imaging, which in ophthalmology is a histology in the living. Okay? For us to take tissue samples and do histology, we can just ask the patient to run through the imaging lab and come out just as he or she were. And I'll show. This is OCT, optical coherence tomography. On the top, you can see the various layers of the tissue, which are color-coded. And on the bottom, you can see various pathologies, fluid, holes, various common retinal pathologies. There's a catch in this slide. There's something very wrong with it, and I wonder if any of the people not in ophthalmology would pick it up. The problem is that this is perhaps 2 generations back. This is old archaeological OCT. And today, this is what we can get. And you can see the difference. You can actually count the 10 layers that compose the retina. And if I picked up with a very small forceps 3 red blood cells, and I actually placed them on the tissue, you would see them up on the top. That's correct to scale. So these are 7 micron red blood cells that you can see in that green circle. And this is histology in a living person. That's a normal eye in a living person. No damage, no harm, no injections. So that's where we are today. You can see how powerful this modality is. This is a very pathological retina with fluid under the retina on the right and various pathologies that the best observer in the world would not be able to pick up on a slit lamp exam, but we can now see it on the OCT. And what you see here is the future. One of the ways to break the envelope in visualization, this is true in astronomy and in looking at very small things, is adaptive optics. And utilizing these tools, you can actually on the left see small foveal cones and actually count them. And on the right, you can see the mosaic of the cones and the surrounding rods in the healthy, living human retina. So that's just a taste or a glimpse of what diagnostics in ophthalmology can do without needing tissue sample. I don't know how many of the people in the audience are surgeons, but one of the most problematic aspects of surgery is that there's never enough OR time. I've never met a resident who said, I operate enough, or perhaps too much. I've met fellows that said they've operated too much, but never a resident. And even experienced surgeons don't tackle enough rare events. So we could discuss a specific rare event during surgery, and an experienced surgeon with 10 or 20 years experience may say, I've only done or seen that twice in my career. So the question is, how do we get more mileage out of the set OR time, which is not going to expand significantly in the near future? And what I tell my residents is videotape everything. And the reason is, you never know when something interesting is going to happen. A complication may occur. There may be a need to look back at the surgery because something weird or unusual is happening in the post-operative course. And if you have the video, you're going to learn. If you don't have the video, you've lost the lesson. And in this talk, I'm going to talk in various aspects about the process of learning and about how to become better. And one of the problems in medicine is that while you're in medical school, everything is very structured, you're spoon-fed, and you become knowledgeable very quickly, very efficiently. In the residency, so-so. Afterwards, you're on your own. If you want, you'll learn, and if you don't, you'll just stagnate. And in our department, we're starting to construct and create tools that will allow us or even enforce us to learn. So when you don't have a video, the normal response is, I hope this never happens to me again, sometimes with a knock on wood. When you have a video, you run into a process that says, what did I do wrong? How can I prevent it from happening again? And just as important, how should I deal with it next time it occurs? We'll talk about learning a little bit towards the end of the talk. Dissecting the conjunctiva is part of glaucoma surgery. And what I noticed, which was not obvious or common knowledge, but it was under the flashlight, is that even though we do the surgery here, in this area, and in a minute we'll see it in cross-section, the surgery fails in this area. That's where we get failure. And if we want to look at a cross-section area, this is where we do the surgery. We create a path for the fluid to leave the eye and accumulate in this area. And this is where we fail. And when you start thinking about it, you say, but I was never there. But then you notice that actually I was there, but I never paid attention to that step in the surgery. And what does failure in glaucoma mean? This is a nice post-surgical outcome with a bleb, a pocket of fluid under the conjunctiva. That looks great. And this is a very nice analogy of the wall and the color and the shape of this bleb. And you can see that fluid is leaving the eye and then gets dissolved and absorbed by blood vessels, capillaries. In this case, you have a ring of steel, a scarred ring. You can see it here very well, that limits the size of this vacuole. The wall becomes very thin, and this is what it looks like. And eventually, unfortunately, bacteria cross this very thin wall, and the eye gets infected. This is basically the wall of the eye when you think of it. You can see it in the schematic here. And what I try doing is, how can we dissect a very large area through a very small opening? Very simple issues. It's surprising that the simple questions usually need simple solutions, and sometimes we don't have them. So what I developed is something that's almost trivial. It's an instrument that looks like this and is now part of the glaucoma tray all over the world. And it's nothing more than an oval ball bearing on a stick, sort of like a lollipop. Unfortunately, I have not spent marketing and interactions in promoting this in other disciplines, because it's clear, and you'll see in a minute how we work with it, that if you want to isolate a nerve during orthopedic surgery, or you want to cleave 2 layers of tissue in neurosurgical surgeries, this concept is very trivial. It's about finding the planes between tissues and cleaving or dissecting the plane without harming any of the tissues on both sides. So basically, the next portion of the talk will discuss cataract surgery very briefly. And you can see on the left an intraocular lens. This is what we implant in somebody's eye. And when they ask us, is it going to last? Does it need replacing? We give them a 100 years warranty for that lens. And this is what that same lens looks like inside the eye, as you can see here. This is a real person. That's not, a schematic. That's a real eye, a real person, and you can see the lens sitting centered in the eye. You can see that it doesn't always work the way we want. And this is a decentered artificial lens. This one is not just decentered, but is also tilted, as opposed to crystalline or real lenses, the lenses we are born with that are also decentered in these cases and need extraction. You can see on the top a very dense cataract. This person can barely see something moving in front of their eyes. They cannot read, visualize faces, recognize them, or anything that we call vision. But they can perhaps tell if it's day or night. In another example of a very dense cataract, and this is probably the densest of the cataracts that we see. And this is real histology. This is in the lab. You can see how dense and dark and, trust us, hard this lens is. In the 80s, the Beatles were already history, but it's not that many years away, and I want to show you how cataract surgery was at the time.
This is a number 64 beaver blade, which is used to make a groove along the limbus, which is used as a mark for the scissors when the eye is opened. These are some scissors known as Castro Viejo scissors, which follow the groove to make the incision. The lens is gently rocked free. You can see the stress on the anterior capsule as Dr. Kohler gently removes this lens, which is pulled free from the eye. Capsule and all, so it's an intracapsular procedure because both the capsule and the lens were removed. Now it's simply a matter of suturing the eye closed. In this case, Dr. Kohler did not place a lens. It was common early on to use contact lenses for rehabilitation. It's a beautiful closure.
We often say that beautiful is in the eye of the beholder. And when a lens isn't implanted, you have very thick spectacles. And when you look at these brothers or maybe twins, and you ask yourself, why did they undergo cataract at such an early age? You start running your differential diagnosis. Cataract today is the most common eye surgery, and perhaps the most common surgery performed in hospitals. It has by far the least complications of all eye surgeries, even though it's a very complex and difficult surgery to perform. And I would guess that the relatively low number of complications has to do with the high volume and the fact that it's a very mature procedure. All the little aspects and the pitfalls were already addressed scientifically and very accurately, and solutions were found to most of the issues in the surgery. It's not the same in other disciplines in ophthalmology. And it's a real miracle. A person can walk into this building blind and leave after an hour or hour and a half seeing. I can think of very few examples, at least in ophthalmology, of a miracle. Refractive surgery is also a miracle because suddenly people see and they express it. We were reborn, but that's more in the cosmetic arena, even though the feeling of the patients is dramatic, but it's not a disease. It's more of a quality of life issue. you know, LASIK, refractive surgery. But when we talk about real blindness, about helping the population, it's a miracle. And we see it every day. We're immune to it. We grew thick skin and we no longer think it's a big deal. But every so often, the patient just opens their eyes and says, I was born again. And sometimes people say, I did not even realize how bad I saw. So I'll show you an example of what cataract surgery looks like today.
Finally, I will show you a case of the cataract surgery using the Akahoshi Phaco Bridge Jumper. Thanks to the shortened ultrasound time and minimal damage to the corneal wound, a self-sealing clear corneal cataract surgery can be performed quite easily.
This is the lens, the cataract, that is going to be removed in a minute. You can see how this instrument eats or absorbs the relatively hard lens. It implies a technology which is ultrasound, and it's a little bit like the instrument that removes the calcium from the teeth. You know, that it's the same kind of technology. The eye's filled with a jelly, something a little bit like honey, to create space. And now an artificial lens is implanted into the eye. It's foldable so it opens up, and you'll see that it will sit in the smack center. It may take a few more minutes until it's completely flat. Here at Rambam, the waiting list for a cataract is around 300 patients. And the surprising thing is, for every patient we operate, and we're operating between 2 and 3 times as many patients as happened 2 or 3 years ago, 2 new patients show up. So basically, if you're naive to think you can close your waiting list, you don't understand the dynamics of medicine. And it's good because we are shunting patients from other waiting lists elsewhere. Because hopefully people say we can get the surgery in Rambam and we can get good quality surgery. And again, 1 hour of operating room time will make one of these 300 blind people, especially if they have dense cataract in both eyes, seeing again. A short word about surgery. When I received my position here, it was even years earlier, it was obvious to me that we're nowhere near our capabilities as surgeons. We can be far better than what we are. I have the same feeling about the educational system. You put your child in elementary school and you say, they can do so much more with my child than what you get back. And first of all, if you set up very high standards, even if you only get 50 or 75%, you're doing a nice thing. And a few months ago, I declared in the department, I tied myself, and I said that in our department, if a resident cannot do a complete cataract 1 year after they started residency, something is wrong with their surgical skills. And you have to understand that in other departments, you're barely allowed to walk into the OR in your first year. And more than that, I said if after 2 years, the doctor cannot hold an entire day doing 5, 6 sequential cataracts by him or herself, maybe they chose the wrong profession. And when I initially said it, people thought I was crazy and, there's no way that'll work. But gladly I can say from this podium that early next week, our first resident is going to fly to India and spend a month doing about 60 cataracts, between 50 and 60 cataracts, which is the requirement for your entire residency. So you can squeeze that in a month. And hopefully, when our residents start rotating through this very unusual and exciting opportunity, we will start seeing much better surgeons at a much earlier age. We will have far less complications that are resulting from the learning curve, and we'll be able to work much more efficiently in the OR, because your first case is 2 hours, and your 60th case can be 60, 30, or maybe 25 minutes. And the question is, how can we do that to the Indians, to the people in India? And the answer is that the payment that this relatively expensive course costs goes to pay for the technology and the disposables so that indigent, very poor Indians that barely have a piece of bread to eat can get cataract that is Western standard with a foldable lens and small incision, sutureless, just like you saw. So in my opinion, it's a win-win-win-win situation. And I hope that in my department, surgeons will grow that will outperform their teachers based on the fact that very early on, we nourished them and provided them with what you need in the soil in order to grow, and time will tell. A word about iridotomy. Angle closure glaucoma is the most prevalent, curable reason for blindness in the world. You can go blind for many, many reasons. Only 2 of them, in my opinion, and you guys can correct me, are curable. That's cataract and angle closure glaucoma. And all you have to do is create a little hole in the iris, one that looks like this. Not everybody needs that hole, but if your eye is inclined to develop angle closure glaucoma, this will cure you, and you can see that this hole is open. That's what we call retroillumination. It's like the red eyes in photos or the red eyes of cats in the night, because light is shining through that hole, and you can see under very high magnification, this is the pupil margin, that, the tissue is damaged in a way, but the hole is there. What I set out was to develop a new kind of lens, which just recently was launched, and the intent was to be able to do finer and better iridotomy holes. Just to understand the burden of disease here, there were thoughts that lasers would be sent to places like India and China, where because of the Asian and shape of the eye, they are much more inclined, Japan, to this kind of disease. And people who are not doctors or even nurses would be trained just to make these holes, to shoot these holes. And they would work 24 hours around the clock, How would you bring the people in? How would you screen who needs it and who doesn't? Complex questions. But this is a curable kind of procedure that takes 2 minutes. Net, you sit the patient, you explain to him, you sign him, but the actual laser, 2 minutes, 1 minute. So it's something that there's a huge world interest in promoting and being able to do in a safer manner. And this lens uses something which is a little complex, indentation gonioscopy. But in a sense, by squeezing on a cornea in a certain way, we're able to open the angle. And hence, we're able to perform the iridotomy much more peripherally than with other lenses and mechanisms. And you can see here that the more peripheral you are along the iris, the thinner the iris is. You can see that on a histological specimen. It's very clear. So this is where we want to create the hole, not here. And with this lens that has aspherical optics, you can get a much tighter laser spot, and hence less collateral iris damage, less inflammation, and also the same results with much lower energy. This next section throws us into the world of more basic or non-commercial or short-term beneficial kind of research. The research that stems from curiosity, from trying to understand or know the eye a little bit better. And I chose this topic because there's like a story or a theme here which has a beginning and an end, and I'd like to run and walk you through it. I'm sure this is not the slide you expected. And the question is this lung cancer or a metastatic disease? And people who are good radiologists, they can look at this X-ray and tell you, it's one or the other. But the question is it fair to trust imaging and create a whole pillar of knowledge based on imaging when you've never sampled the actual tissue? If you've never gone into that lung and checked if what you think based on the contrast and the borders and the growth rate and everything is really what you think it is. In other words, should we trust imaging without ever obtaining histological proof? And my initial question was, do we have any histological validation for a procedure that in glaucoma we do very, very common? We measure the thickness of the retinal nerve fiber layer. Because that's basically all the retinal nerve fiber layer together creates the optic nerve. And in glaucoma, if the optic nerve we're born with has 1 million tunnels or wires of information, it's like 1 million pixels. As the glaucoma eats up or takes away your vision, these pixels suddenly disappear. And the optic nerve atrophies and becomes thinner. And this is the way we measure whether somebody has glaucoma and whether the treatment that we gave slowed or even halted the progression of the disease. So based on retinal nerve fiber layer thickness in imaging, we would take one patient to surgery, and the other patient will say, everything is fine, just come back in 6 months. So it's important. And this summarizes the work that we did, and I'll run through it. The first shot was basically to stop and say, let's learn what's already done. This is something that very often we Israelis forget to do. We jump into the process, to the procedure, and then we come to the IP people, and they do a huge Google test, and they say, there's already a patent on it. It was invented before, exactly. So we wanted to see what's out there. And what I want to show you now is a concept that I call it subject impact factor. You know that if you want to know how good a journal is, they have impact factors. You can, there's ranks and scores and everything. If you want to know how good a person is, a researcher, then you can measure their CV, weigh it. There's equations and, there's quantity and quality. But there's also an impact factor for a subject or a topic. So if you have 3 fields you're considering to go into your PhD, you could easily plot a graph in the last 5 or 10 years about your topic, like nanotechnology and, I don't know, vision loss, and you could get a feel in the literature for what's going on. Is there a buzz around this topic? Are other people researching it? When I came to the Technion and I heard about ubiquitin, I realized for the first time that maybe it's actually good to be studying a topic that nobody else is researching. But usually it's the other way around. So we looked at the Medline hits, and we saw that there's a tremendous amount of publications on the various instruments that we use in glaucoma to image the retinal nerve fiber layer, and it's quite obvious which is the one that emerged as the winner, just based on the number of publications. Without doing ROC curves or positive and negative predictive rates, this one has attracted most of the attention, and the ophthalmologists will agree that this indeed is the situation. And then we went on to ask about histological measurements of RNFL, and we saw that this is all we could find. That's all there is in the literature. And we summarized in that review, not a single seeing eye with glaucoma was ever processed for RNFL thickness measurements. So obviously we're building a very tall tower and sending people to surgery based on very little evidence that that thing on the chest X-ray is indeed what we think it is. And more surprising was that every study sectioned the retina with a keratome, you know, the tissue, the paraffin block, in different ways, because there's no good way to section the retina. And you can see here. And when we looked at the data, we actually plotted in the review all the data that was existing in the literature. And we plotted it in graphs. And these are the human studies. That's very, very poor data. That really doesn't tell you anything. So then we went on to develop a novel technique for sectioning the retina, which has a sort of a topological glitch or, you know, outside the box thinking to it. What we want to get eventually is a pattern that looks like this. This is how the imaging provides us the data. The shade is the normative range, and this is one specific eye which is healthy. It's even very healthy. And this one is sort of average healthy. What we do is we sample the thickness of the retinal nerve fiber layer all around the nerve. And if we sum up all those thicknesses, we get the cross-sectional area of the retinal nerve fiber layer, which becomes the optic nerve. So the question is, how do we get that specific data by sectioning the eye vertically or horizontally? It's very difficult, and you're running into dozens or hundreds of slides, and everything goes out of alignment. Very complicated. So what do? So this is how we'd like to section the retina. This is perhaps as close as we can do it by shaving the corners, but technically it's not possible to do. And if we got a good sample all around the nerve, this would be 100 point. This is exactly what we'd like to get. And if we had to close our eyes and imagine what such a section would look like, this is what it would look like from a pig eye. And this is what it would look like from a human eye. And you can see that the most inner layer is the retinal nerve fiber layer. And we have thickening superiorly, then it's thin, we're going around, and then thickening superiorly. And we'll see the graphs. And we get what we call a double hump or a twin peak pattern. So how can we arrive at these sections? Basically, instead of thinking of the retina as something flat and smooth, you can think of it as an umbrella. And if you close the umbrella and you then section along these lines, you get perfect ring samples that are at a set distance from the optic nerve. In other words, exactly what you're looking for. They look like this. And then we set up to try to solve a dilemma in the literature about split bundles. And I'll just show it really quickly. In some eyes, we see that there's two different bundles superiorly. And most of the community believe that this is an artifact because we have two bundles that surround the macula. Why would there be a second bundle that doesn't go anywhere? There's very few ganglion cells in this area. So the idea was that this is probably an artifact, and we set out to try and figure out whether it's true or not, even though some people said, you know what, there's some hints in photographs that maybe this is real and not an artifact, as you can see here. So we started plotting eyes, and these are regular eyes. But every once in a while, we actually saw an eye that has a split superior bundle. These are 4 of them. And we could calculate that from our sample size, about 1/3 of healthy eyes, in fact, have a split superior bundle. Last, and we're approaching the end of the lecture, I wanted to do the real thing. And here, maybe you guys would volunteer or help me out. And let's brainstorm. I would really love to have one of you or maybe one of your friends agree and, consent to have imaging done on their eye. It's naive. I've had imaging done hundreds of times on me just when we calibrate and when I want to teach people how to do imaging. So we'd have good imaging of the retinal nerve fiber layer. And then the next day, that volunteer would lend us their eye permanently. We'll take it out and we'll do histology. And then we'll have the real thing. We'll have imaging and histology on the same eye, very close together, like the next day. So we would be absolutely sure. And then we could finally crack that imaging, histology, fitting or not fitting together. So this is what I set out to do. And I wanted to keep my license. So this has to be a IRB, or what we call Helsinki approved. And I thought about it a lot, and I said, I'm going to crack this up. And in fact, we did, and we have a paper in Eye. And it says, retinal nerve fiber layer imaging compared with histological measurements in a human eye. And the question is, how did we do it? So in medicine, just like folding the retina into an umbrella, you have to be a little creative and see if you can work around your limitations. And you remember the chest X-ray. So I ask, are there any volunteers here? And what happened is I spread the word out. And one day I got an email from a very good friend of mine from India. This is different India than the India that helps us with training cataract surgeons. And he said, I have a patient with a malignant tumor that has surrounded the eye. This is one of those BCC, SCC, those nasty, infiltrative, deadly tumors. And we want to take out the eye as well as the orbit and the lids, and it's a terrible surgery. But it's either that or dying. And he appears a relatively young guy. You can see the tumor here surrounding the eye. And what he told me is he sees 20/20. It's a normal eye. And I said, will he consent to have imaging done? He said, no problem. It's 5 minutes of our technician time. So we rushed an IRB, and they did the imaging, and the next day, or maybe 2 days later, the eye was removed. And after they did all the necessary sampling and diagnosing as far as, treatment and chemo and so forth, the eye was available for the umbrella technique. And basically what you can see here is the one form of imaging, which is called the polarimetry, and histology. And here you can see OCT, which is, remember, the one that won the best technology versus that same histology. But now something popped up. We knew it, but it also popped up when we sent the article for review. People said, your histological measurements are not accurate, because when the person dies, the tissue swells. And then you take the tissue and you put it in paraffin, and it dehydrates. And then you put it in the heat, and you cut it, and so forth. And eventually, the proportions stay, but the real thickness is nowhere like it was in the living human eye. And we know that, when we have ion in ischemic event in the optic nerve, the swelling like papilledema, the whole thickness changes. So basically, at the end of all that, we're left with two proportional measurements, but we can never align micron per micron and calibrate the two. And today I stand in front of you and I say, I don't know which is more real, which needs to be calibrated with which. So that's research. You know, there's always room for the next generation. And surprise volunteer we found had a split superior bundle. So it was just kind of wrapping up what we've done. And in the last 2 or 3 minutes, I want to talk about what I call feedback loop, which to me is by far the most important concept in this talk. And more than that, I think feedback loop is what makes us learn. Without it, there's no learning and no progress. And I think clinical research is just one example of a feedback loop. And I'll try to explain what it is. The loop is composed of 3 parts. There's an action, there's a consequence, and there has to be the recognition that one brought about the other. It starts simple, but in a minute you'll see why it's such an important concept and why we don't use it enough and where we pay the price. So I think puppy training is the classical example of a feedback loop. And unless you convince the puppy that he gets spanked with a paper, with a rolled newspaper because of what he left on the carpet, and unless you can shrink the time intervals so that, you know, there's the recognition that one brought about the other, there will be no learning, no improving. And this feedback loop, in my opinion, explains why we are such good cataract surgeons, but only so-so in glaucoma surgery. It has to do with the feedback interval. When you draw blood, you get instant feedback. You know if you're the king or if you need to crawl under the carpet. When you sit for a medical school test, in 2 weeks, hopefully, you get your score and you got your feedback. But when you decide to go into medicine, maybe only when you're an intern, you get feedback whether you chose wisely. And when you raise your children, it takes at least 18 years, and some say 30, to know if the decisions you made early on were correct. During cataract surgery, one wrong movement and a heavenly hand falls from the sky and spanks you on your hand. And that really, really hurts. In contrast, when you do glaucoma surgery, one wrong maneuver and the surgery will also fail. But that will happen a month or a year later. And it's very unlikely that when you see the patient, if you see him or her, and you saw that you failed, you have any way of guessing what did I do wrong in that specific surgery, because all your surgeries start blending together after a few days. So you cannot remember whether there was more bleeding or more diathermy, or maybe your incision was longer or deeper, or maybe you used a different kind of knife. No learning. So remember, it's all about feedback loops. You will never get better at what you do unless you seek feedback on what you're doing wrong. And sometimes that feedback is just nowhere to be found. And this is the reason I'm almost having a battle with my residents, that everything needs to be videotaped, even if you won't look at the video. Because there will be a day, tomorrow or next week or next month, where you'll say, damn it, if I only had the video, I would learn why the lens popped out in the wrong direction, and I will figure out how and what I need to do to prevent it happening again. Loose feedback loops explain why our educational system is so lousy. Some may say that there are no feedback loops in the Israeli or general education system, and why perhaps it's easier to write a peer-reviewed paper than to succeed in educating your children. Thank you very much.